Good afternoon. First, I'd like to say thank you for that lovely introduction. And I'd like to say that I am so pleased and honoured to be receiving this award from the Physiological Society. And it's particularly a great honour because I'm interested in blood pressure regulation. And Sir Edward Sharpie-Schaefer really contributed hugely to our understanding of blood pressure regulation by, as you know, his co-discovery of adrenaline. My talk today revisits an old hypothesis regarding hypertension and how it might be self-protection for the brain. And we have novel data regarding this from the University of Bristol. Now, this hypothesis is called the selfish brain hypothesis, where cerebral hyperperfusion triggers an increased blood pressure to maintain cerebral perfusion. And this is where hypertension really becomes essential. So what is the problem with essential hypertension? Well, 1 billion people in the world have hypertension, and this equates to 25% of the world's adult population. And it's expected to rise to 1.56 billion in about 9 years' time. So what is the problem with this? Well, high blood pressure is the leading risk factor, modifiable risk factor, for all-cause mortality. And the other problem is that it's linked to cerebral vascular disease, particularly stroke. And in particular, a lacuna-type stroke, which is caused by occlusion of the small penetrating arteries perfusing the subcortical structures like the brainstem, the basal ganglia, and the deep cerebral white matter. And just to show you what a lacuna infarct looks like on an MRI scan, I've got two images to show you. There, the yellow arrow is pointing to an infarct region, which is black on the MRI scan. And for comparison, on your right, there's a normal MRI scan with no infarct region. And linked to this is cerebral small vessel disease, where two types of remodeling contribute to this. Inward remodeling, there's two types of inward remodeling, and this is indicated in the figure. There's eutrophic remodeling, where the circumference of the inner and outer vessel decreases in size, and this is called eutrophic remodeling. And the other type of remodeling is hypertrophic, where the wall thickness of the vessel increases, encroaching onto the lumen space. Now, in both types of remodeling, the lumen size basically decreases, increasing resistance to blood flow. Now, this usually causes hypoperfusion, which goes some way to explaining why hypertension is a risk factor for cognitive decline and dementia. But perhaps the real problem is treating high blood pressure. And a recent study based in the USA illustrated this nicely. They showed that in their hypertensives, about 75% were being treated for high blood pressure. But of these patients being treated, only 53% had a controlled blood pressure below target levels. Now, this poor control causes a massive problem for the NHS, particularly because Public Health England estimated that hypertension costs about £2 billion per year. And we can all agree this is a massive amount for a modifiable risk factor. Now, this poor control may indicate two things. First, that adherence to medication is pretty poor. And second, that the drugs using to treat hypertension in these patients aren't actually targeting the real cause of high blood pressure in these patients, suggesting that we might not really understand the cause of high blood pressure in humans. So what does cause hypertension? Well, as I said, we don't really understand all the factors that lead to high blood pressure in humans. We do know that it's multifactorial, with factors like obesity, genes, and poor diet predisposing people to the development of high blood pressure. But one common factor is that the activity of the sympathetic nervous system is elevated in hypertension, in animal models of hypertension and in humans. And this is illustrated here in this figure from Smith et al. And what they did is they took different groups of people with different levels of blood pressure and measured their sympathetic nerve activity. So they've got people with normal blood pressure, people with high normal blood pressure, and through to people with stage 1 hypertension. And as you can see, as blood pressure increases, so does sympathetic nerve activity. Now, this increase in sympathetic nerve activity contributes to the typical phenotype that we see in hypertension. So an increased total peripheral resistance and an increased renal vascular resistance, for example. But one problem is that we don't really know what causes the increase in sympathetic nerve activity and high blood pressure in the first place. Now, as I started with, one theory is that the brain might be to blame for this increase in sympathetic nerve activity due to problems with the cerebral perfusion. But before I go into the selfish brain hypothesis, I'm just going to remind you of the anatomy of the cerebral vessels. And this is because I'm going to talk about these vessels from here onwards. And I'm also going to use this figure from here onwards. So just to orientate you on this figure, we've got the vertebral arteries. Well, the brain is perfused by 4 main vessels. We've got the vertebral arteries here on the figure and the internal carotid arteries here on the figure. The vertebral arteries come up to fuse and make the basilar, and the basilar artery and the internal carotid arteries terminate at the circle of Willis. Now, the circle of Willis forms the brain's collateral circulation. The internal carotid arteries and the anterior vessels of the circle of Willis, they are really important for perfusing the anterior regions of the brain, but the vertebral arteries, the basilar and the posterior communicating arteries are really important for perfusing all the posterior regions of the brain. Now, just to show you how important the circle of Willis is, if your basilar artery becomes blocked somewhere around here, your posterior communicating arteries will shunt blood from the anterior circulation to the posterior circulation to ensure adequate perfusion of the brain. So getting on to the selfish brain hypothesis now. Well, the first mention of this as a role in blood pressure or hypertension was first mentioned in the literature by Seymour Ketty and co-workers in 1948, and he's just pictured here. They found that cerebral vascular resistance is elevated in humans with hypertension, and they had a few hypotheses regarding this. Now, one of them was, and I quote, that in essential hypertension, there may be a primary cerebral vascular constriction accompanied by a secondary and compensatory hypertension, which maintains cerebral blood flow. And they based this on Harvey Cushing's classic experiments from 1901, who showed that when cerebral blood flow is reduced in dogs by an increase in intracranial pressure, that he saw an increase in blood pressure, which was trying to maintain perfusion to the brain. But Seymour Ketty and his colleagues abandoned this hypothesis in favour of the reverse hypothesis, and this is now the prevailing dogma in hypertension. The elevated cerebral vascular resistance is actually caused by hypertension. So the elevated cerebral vascular resistance is trying to protect the brain against the deleterious effects of high blood pressure. Now, later, John Dickinson revisited this hypothesis, and he's pictured here. And he decided to revisit this hypothesis because he saw that in many of his hypertensive patients, the vertebral arteries had become narrowed compared to his normotensive patients. Now, he thought that these smaller arteries would be increasing the cerebral vascular resistance, causing a lower blood pressure. Now, he specifically saw in his patients that the vertebral arteries had become narrowed. Therefore, he hypothesized that hyperperfusion of the brain would cause an increased sympathetic nerve activity and blood pressure to maintain perfusion. And this is called cerebral vascular hypertension. And one finding that caused John Dickinson to really believe in the selfish brain hypothesis was that he found an inverse relationship between mean ante-mortem blood pressure and blood flow measured in the vertebral arteries. So that somebody with a really high mean ante-mortem blood pressure had a very low flow in their vertebral arteries, indicating an increased vascular resistance. Now, importantly, they found no such relationship in the femoral artery, suggesting it wasn't a global phenomenon. But there were two problems with this. They had no data from alive humans to confirm this, and they had no data to prove cause and effect, which was something that particularly drove John Dickinson mad. So John Dickinson worked with Julian Payton to try and establish cause and effect in a rat model of hypertension. And he used spontaneously hypertensive rats, which are a good model of human hypertension. They're an inbred strain of animals where their hypertension has no primary cause, but is driven by high sympathetic nerve activity, so it's similar to humans. They found that arterial remodeling, so narrowing of some of the main cerebral vessels, occurred before the onset of hypertension in these animals. Just to illustrate this here, I've got two histological sections to show you. The top one shows a cross-section of the basilar artery in a normotensive animal, and the bottom one shows a cross-section of the basilar artery in a pre-hypertensive, spontaneously hypertensive rat. So this rat hasn't developed hypertension yet, but will do in the future. As you can see, the basilar artery is clearly remodeled in this animal. So it's become narrowed. What do these narrow vessels mean for blood flow in these animals? Well, the figure on your right tries to illustrate this. It shows that for normotensive animals, which are the Wistar animals, and the spontaneously hypertensive rats, to have the same blood flow through the basilar arteries, the hypertensive rats need a higher blood pressure. This suggests that in the hypertensive animals, their blood pressure is needed to maintain perfusion to the brain in the face of elevated resistance caused by this vascular remodeling. But this doesn't prove that brain hyperperfusion causes reflex increases in sympathetic nerve activity and hypertension in these animals. So what Julian Payton and his group did is they caused brainstem hyperperfusion and measured blood pressure and sympathetic nerve activity responses in hypertensive and normotensive animals. And they caused brainstem hypoperfusion by bilateral occlusion of the vertebral arteries. Now, what they found was that in the hypertensive rats, which are in red, there was a bigger increase in sympathetic nerve activity, shown here, and perfusion pressure, shown here, in response to brainstem hypoxia, which suggests that these animals are more sensitive to changes in tissue perfusion than the normotensive animals. But could this mechanism actually explain the development of human hypertension in some people? Well, my group at the University of Bristol became interested in this, and we ended up completing two studies. We completed a retrospective study and a prospective study. In the retrospective study, we examined 131 patients attending our group's research hypertension clinic. Now, as part of their routine clinical examination, they get a brain MRI. So we use 3D time-of-flight angiographic images to examine anatomical variants in the vertebral artery, the basilar artery, and the internal carotid artery. And we were specifically looking for narrowing or hypoplasia in these vessels. So why were we looking at hypoplasia? What is it? Hypoplasia is actually a congenital abnormality where the vessel hasn't developed or it's underdeveloped. And the most common variant in the cerebral circulation is hypoplasia of the vertebral arteries. Just to illustrate what vertebral artery hypoplasia looks like, I've got some figures here. On your left shows normal vertebral artery anatomy, where the left and right vertebral artery are roughly the same size, but the figures on your right show right and left vertebral artery hypoplasia. Now, vertebral artery hypoplasia is defined as a uniformly narrowed vessel of less than 2 millimeters in diameter. We also looked for anatomical variants in the circle of Willis. Now, there's lots of types of anatomical variants that can be found in the human cerebral circulation, and these are them all. I'm not going to go through them all, but we did examine all of our angiograms for these. But I will go through the ones that we were specifically interested in. In the anterior circulation, we were specifically interested in whether somebody had a hypoplastic or missing anterior communicating artery. So they could have they could be missing one artery or both of these vessels. We were also interested in the posterior variants, and the main variant that we were interested in was whether somebody had a hypoplastic or missing posterior communicating artery. This could occur in one or both vessels. We called this an incomplete posterior circle of Willis. So we hypothesized that, based on some of John Dickinson's findings, that the vertebral artery and the vessels of the circle of Willis would become narrowed. We didn't have a control group to compare these two, so we had to use what was reported in the literature for normotensives. So we used a reference standard. We didn't actually find any differences in prevalence in hypoplasia in the internal carotid arteries, but what we did find was a difference in prevalence in vertebral artery hypoplasia between hypertensives and what's reported in the reference standards. Just to show you what vertebral artery hypoplasia looks like on an angiogram, I've got two 3D volume rendered angiograms to show you. On your left, it shows normal vertebral anatomy in a normotensive patient. On your right, you can see clearly that there's left vertebral artery hypoplasia, so that the vessel's really narrow and it takes a really tortuous course up to the basilar artery, and this is in a hypertensive male. So what did we find? We found in our hypertensives there was a much higher prevalence of vertebral artery hypoplasia in our hypertensives compared to our normotensives. The odds ratio indicated that if you had this type of variant, you were 2.7 times more likely to have hypertension, or vice versa. The other difference we found in the anatomy of the cerebral circulation was a difference in prevalence in the incomplete posterior circle of Willis. Just to remind you what this is where you could have a hypoplastic or missing posterior communicating artery. You could be missing one or both. Just to show you what this looks like on the angiograms, on your left it shows a normal angiogram where both posterior communicating arteries are present here. This is in a normotensive patient. On your right shows an incomplete posterior circle of Willis where they're missing both of their posterior communicating arteries. That's in a hypertensive male. So we found that in the hypertensives, they had a higher prevalence of an incomplete posterior circle of Willis compared to what was reported in reference standards. So the odds ratio indicated that if you have this type of variant, you're 3.1 times more likely to have hypertension or vice versa. Now, we were specifically interested in the prevalence of having both. And this is because if you have a hypoplastic vertebral artery and you're missing both of your posterior communicating arteries, you're reliant on one vertebral artery to maintain the posterior circulation. Now, this has obvious limitations if this vessel becomes blocked or stenotic. So what did we find? We found that in the hypertensives, there was a much higher prevalence of this type of having both types of anatomical variants compared to what's reported in the reference standards. So if you have both types of variants, you're 5.3 times more likely to have hypertension or vice versa. So first, what have we now contributed to the literature that supports the selfish brain hypothesis that John Dickinson collected? Well, we've shown that congenital variants are linked to hypertension. So congenital narrowing is linked to high blood pressure. By sheer definition, congenital occurs, obviously, before the development of hypertension. But there's three main limitations of doing a study like this. First, we actually haven't proved that hypertension is caused by large vessel narrowing and cerebral hypoperfusion. The second problem is that we had to compare to reference standards. So we had no control group that was demographically matched to our hypertensives. And of course, the analysis wasn't blinded. So this led us to do a prospective trial, where the aim was to actually answer two questions. The first was, is cerebral blood flow actually lower in our hypertensive patients? And the second was, is there a higher prevalence of congenital cerebral vascular abnormalities in hypertension? We recruited 77 hypertensives, 49 age-matched normotensives, and we confirmed their blood pressure status via office and ambulatory blood pressure monitoring, and the analysis was blinded. We took several measurements using MRI. The first was 3D time-of-flight angiography, and we used this to look at the cerebral vessel anatomy, and we looked for all the variants that we described in our retrospective study. We measured cerebral blood flow using phase contrast imaging. And just to explain how this works, phase contrast imaging allows you to measure blood flow directly from a vessel. So we measure blood flow in the internal carotid arteries, the vertebral arteries, and the basilar artery. Now, phase contrast imaging provides a velocity map of blood in a cross-section of the vessel. And velocity maps are just shown here in the left and right vertebral artery of a normotensive. So each big square represents the time in the cardiac cycle. So in your left vertebral artery, you've got 9 time points in the cardiac cycle. Each small square represents velocity of blood in that voxel. And just to, I should say that dark velocity, the dark colour means more velocity, and the lighter colour indicates a slower velocity. And just to compare the velocity maps in a hypertensive patient, you can already see that the velocity is lower in the vertebral arteries at different types in the cardiac cycle compared to the normotensive patient. To calculate flow, we actually take the mean velocity in the vessel and multiply it by cross-sectional area, and we do that at each point in the cardiac cycle. We scale the blood flow for brain tissue volume, and we defined total flow to the brain as the sum of flow in the basilar and internal carotid arteries. We also measured regional cerebral perfusion using phase contrast, pseudo-continuous arterial spin labeling. Now, this allows you to measure blood flow in any region of the brain that you're interested in. And we measured cerebral vascular resistance as the mean arterial pressure measured during the phase contrast scan divided by the total arterial blood flow calculated in the phase contrast scan. So what did we find? Well, if I draw your attention to the graph on your left, we found that cerebral blood flow was indeed lower in our hypertensives, shown in the red bar, compared to our normotensives. And on the right, the graph shows you cerebral vascular resistance in these patients. We confirmed that cerebral vascular resistance is indeed elevated in our hypertensive patients compared to normotensive participants. What about regional cerebral perfusion? Well, I wouldn't normally put a big table on a slide, but I thought it illustrated the point that I wanted to make quite well. I wanted to show you that in every region of the brain that we analysed, cerebral perfusion was lower in our hypertensives, shown in yellow, compared to the normotensives, shown in white. So this ranged from the brainstem all the way through to the frontal pole. And what about the prevalence of the congenital variants that I talked about in the retrospective study? We found that vertebral artery hypoplasia and the incidence of having vertebral artery hypoplasia plus an incomplete circle of Willis was higher in our hypertensives, which is shown in red, compared to the normotensives. So if you have either type of variant, you're roughly 3 times more likely to have hypertension. Just to put this into context, if I use body mass index as a predictor of hypertension, I found that in these patients, if they had a body mass index greater than 25 kilograms per meter squared, they were roughly 0.9 times more likely to have hypertension. So how do these anatomical variants actually link to hypertension? We wanted to look at the cerebral blood flow and cerebral vascular resistance in these patients. Basically, we thought that these variants might be linked to lower cerebral blood flow and increased cerebral vascular resistance. So we split the groups into people with vertebral artery hypoplasia and people with normal vertebral anatomy, regardless of their blood pressure status. So what we found, the graph on your left shows that total cerebral blood flow was lower in our participants with vertebral artery hypoplasia compared to the group with normal vertebral anatomy. The graph on your right shows that total cerebral vascular resistance was indeed elevated in patients with vertebral artery hyperplasia compared to people with normal vertebral anatomy. But the problem is that in our group with vertebral artery hyperplasia, this has a disparate amount of hypertensives in the group. So we don't know whether this is driven by hypertension or their vertebral artery anatomy. So what we did is we split people into normotensives and hypertensives with or without vertebral artery hyperplasia. Now, if I draw your attention to the left graph, this shows total cerebral blood flow in the 4 groups. Now, there's 3 findings that I want to point out to you that are important. The first is that in hypertensives with normal vertebral anatomy, so that's these in the solid red bar, they had a lower cerebral blood flow compared to the normotensive patients with normal vertebral anatomy. Now, interestingly, we found that normotensive patients with normal vertebral anatomy had a similar cerebral blood flow compared to the normotensives with vertebral artery hyperplasia. However, in our hypertensive patients who had vertebral artery hyperplasia, so this is the last group here, they had a lower cerebral blood flow compared to their hypertensive counterparts with normal vertebral anatomy. We found a similar pattern when we looked at cerebral vascular resistance. So this led us to conclude 3 things. First, that normotensive patients appear to have the ability to correct for vertebral artery hyperplasia, so they can maintain cerebral blood flow. Because we found a lower cerebral blood flow in our hypertensives with normal vertebral anatomy, this suggests that hypertensives have vascular disease regardless of their vertebral anatomy, which is limiting their cerebral blood flow. But vertebral artery hyperplasia makes cerebral vascular resistance even higher and causes further cerebral hypoperfusion in hypertension. So why isn't blood flow lower in our normotensive patients with vertebral artery hyperplasia? In the literature, it reports that if you have vertebral artery hyperplasia, normally the contralateral vessel will correct for cerebral blood flow, to maintain cerebral blood flow. So we decided to look at basilar flow in the normotensives and hypertensives with normal vertebral anatomy and vertebral artery hyperplasia. We found that in our normotensives, basilar blood flow was the same in people with normal vertebral anatomy and vertebral artery hyperplasia, suggesting that the contralateral vessel is correcting for the narrow vertebral artery, maintaining basilar blood flow. But in our hypertensive patients, there was indeed a lower basilar blood flow in our patients with vertebral artery hyperplasia compared to patients with normal vertebral anatomy, suggesting that their contralateral vessel hasn't corrected for the narrow vessel. But what does vertebral artery hyperplasia actually mean clinically for our hypertensive patients? We decided to look at the incidence of lacunar infarcts in our hypertensive patients. And as you can see, the hypertensive patients with vertebral artery hyperplasia, so they're the ones in the solid red bar, had a much higher prevalence of lacunar infarcts compared to our hypertensive cohort with normal vertebral anatomy. This suggests that vertebral artery hyperplasia does indeed compromise cerebral blood flow and may put hypertensives at risk of a posterior circulation stroke. But we haven't established cause and effect yet, so we come back to the old chicken and egg question, which I think does haunt some human physiologists. We still haven't answered the question whether increased cerebral vascular resistance causes elevated sympathetic nerve activity and hypertension in humans, or whether it's the other way round. So in an attempt to establish cause and effect, we decided to recruit a cross-section of patients with different levels of blood pressure. We recruited a younger and older normotensive group, and I should say that the older normotensive group were the age-matched group for our hypertensives. We then recruited a borderline high blood pressure group. These were defined as people with an office systolic blood pressure of between 135 and 140 millimeters of mercury, and a daytime ambulatory systolic blood pressure of between 130 and 135 millimeters of mercury. We also recruited a group of untreated hypertensive patients. We recruited a group of patients receiving treatment, but they have controlled blood pressure below target levels. And we recruited a group of patients allegedly taking their blood pressure medication, but their blood pressure was poorly controlled. And we tried to answer the question, what occurs first, the rise in cerebral vascular resistance or hypertension, which is mediated by an increased sympathetic nerve activity? So what did we find? Well, if I draw your attention to the black bars first, this shows you cerebral vascular resistance in our different groups. And now the key group is our borderline hypertensive group. What we found was that in our borderline hypertensive group, which is shown in blue, the blue arrows pointing to the group, their cerebral vascular resistance was elevated above that observed in the normotensive groups. But it was similar to the cerebral vascular resistance shown in all of our other hypertensive groups. Now, the key thing was that the finding in sympathetic nerve activity. The sympathetic nerve activity is shown in red. We found that borderline hypertensives had a similar sympathetic nerve activity compared to our normotensive groups, and it was lower than that observed in our hypertensive groups. Now, this suggests that cerebral vascular resistance is elevated before the increase in sympathetic nerve activity and hypertension in our human patients. What does this mean for cerebral blood flow? Well, first, we found that in our borderline hypertensives, which are shown in red, the red bar here, their cerebral blood flow was lower than that observed in the normotensive groups, suggesting that their mean arterial pressure hadn't yet corrected for their higher cerebral vascular resistance. But perhaps the most interesting finding was this. In our untreated hypertensives, they actually had a higher cerebral blood flow than our treated hypertensive group and our uncontrolled hypertensive group, suggesting that their arterial pressure was able to increase cerebral perfusion and maintain it to nearly a similar level seen in normotensives. So this suggests that potentially high blood pressure may actually be self-protection for the brain, and that lowering blood pressure below a critical point may compromise cerebral blood flow in patients. So what does this mean for treating high blood pressure? Well, first, I thought it was pertinent to mention the recent SPRINT trial that's been completed, where they showed that aggressive blood pressure lowering below 115 millimeters of mercury conferred added cardiovascular protection against the risk of having a heart attack, for example. However, if high blood pressure is indeed protection for the brain in some people, aggressively lowering blood pressure may severely compromise cerebral blood flow in some patients. And we don't really know what this means for our risk of cognitive decline and dementia in these patients. We think that specifically patients with these congenital abnormalities or variants that I showed you in the cerebral circulation may be at increased risk of having cerebral hypoperfusion when their blood pressure is aggressively lowered, and in patients with high cerebral vascular resistance. So we raise a new clinical question. How should we treat hypertensive patients with elevated cerebral vascular resistance and or patients with congenital variants in their cerebral circulation? Obviously, a treatment that improves cerebral vascular health and increases cerebral blood flow would be beneficial. So to summarize what I've shown you today, we found that cerebral blood flow is lower in hypertension, and this may be mediated by an increased cerebral vascular resistance. The increased cerebral vascular resistance may occur before the onset of high sympathetic nerve activity and hypertension in humans. The high cerebral vascular resistance may be caused by congenital variants observed in the cerebral circulation in some of our hypertensive patients. treated patients who have controlled blood pressure may have a lower cerebral blood flow compared to untreated patients, which suggests that hypertension may indeed be self-protection for the brain. So I'd like to take some time to make some acknowledgements now. First, I'd like to thank our Bristol Heart Institute Cardionomics group, and in particular, I'd like to thank Julian Payton, particularly for all his patient advice over the last 4 years and for nominating me for this award. And some other people I'd like to say particular thanks to is Jonathan Rodriguez and Esther Warnart, who patiently sat there and analysed MRI scans. And I'd like to also thank Richard Wise for helping us set up a lot of the MRI paradigms. And I'd also like to thank Amy Burchell for running the hypertension clinic and providing lots of hypertensive patients. And I'd also like to thank people that have been important in my career so far. I'd like to thank Michael Joyner, Nisha Sharkudian and Gunnar Volin. I'd like to particularly thank Michael Joyner for giving me the chance to have a postdoc at the Mayo Clinic. And I'd like to thank Nisha Sharkudian for being an excellent mentor for my years at the Mayo Clinic. I'd also like to thank Gunnar Volin for teaching me everything he knew about micronography. And I'd also like to thank Jill Barnes, Erica Verwine, and Darren Casey, who were my fellow postdocs at the Mayo Clinic. And I'd like to thank them particularly for making my time at the Mayo Clinic really nice and making the atmosphere in the lab a really collegiate and collaborative group. And finally, I'd like to thank Rob Shave, who gave me a chance to do a PhD with him. And he really was an excellent PhD supervisor. And I'd like to thank Neil Secker, who gave me the chance to do some of my PhD studies in his lab in Copenhagen. And without that chance, I don't think I would have completed all my studies I needed to for my PhD. Finally, I'd like to thank the Physiological Society for selecting me for this award. And finally, I'd like to say thank you for coming to this lecture today. So thank you.